Chapter 5: Therapy as a Way of Life. Medical Values versus Social Change. The medical model is at the heart of the transsexual empire. It serves as the new theology for the therapeutic and medical priests. From time to time, there are in-house debates about certain elements of the model, but on the whole, it functions at an established and consistent level of orthodoxy. I use the term medical model to mean an ideology that stresses freedom from physical or mental pain or disease, the location of physical or mental problems within the individual or interpersonal context, an approach to human conflicts from a diagnostic and disease perspective to be solved by specialized technical and professional experts. This approach has a profound influence on the study and treatment of transsexualism. For example, if one's basic approach to the problem of transsexualism is from a psychological and medical basis, then many moral issues, as well as socio-political, economic, and environmental problems, are transformed into technical problems. This means also that critical awareness, choice, and responsibility are not perceived as curative, but are replaced by technical cures. Ultimately, one must ask if the transsexual problem is really amenable to surgery and thus a medical model. Is the biomedical imperative that has functioned in other areas, such as genetic technology and psychosurgery, reducible to presuppositions about the nature of women and men? If, as argued in Chapter 3, transsexualism is of socio-political origins, can it be understood and treated by a medical model? The medical model as theoretical and ethical construct. Since the 19th century, especially, problems of alienation have been individualized. With the advent of Freudian psychoanalysis, which was later incorporated into medical psychiatry, health values began to take the place of ethical values of choice, freedom, and understanding. Quote, with the transformation of the religious perspective on man into the scientific, and in particular into the psychiatric, which became fully articulated during the 19th century, there occurred a radical shift in emphasis away from viewing man as responsible agent acting in and on the world, and toward viewing him as a responsive organism being acted upon by biological and social forces. In this process, the imagery and vocabulary of morality were replaced by biological fantasy and psychiatric metaphor. End quote. The medical model has gradually yet consistently treated problems of social alienation in the therapy of closed rooms, and more recently in the small group counseling sessions of family clinics and community health centers. Ernest Becker has contended that initially, quote, the psychoanalytic cure began its work by focusing on the individual. Now it is broadening out to the study and therapy of the family, end quote. I have noted in assessing the theories of Robert Stoller that much of his work involves not only individual but family therapy as well. By thus treating the problem of transsexualism, the medical psychiatric professionals have consistently used a medical model as remedy, failing in their attempts to counsel preoperative transsexuals to adjust to the normative gender identity and role of their anatomical sex. Transsexual clinics and therapists, after extensive evaluations of course, succeeded in adjusting transsexuals to the normative gender identity and role of their desired and opposite anatomical sex. Armed with the medical model and operating on the basis of the narrow health values it generates, therapists speculate about the causes of transsexualism and make therapeutic diagnoses within the same framework that generated the problem to begin with. That is, within a role-defined society and its definitions of masculinity and femininity. The goal in this triumph of the therapeutic is supposedly good health, but good health achieved at the expense of critical awareness and exploration of the oppressiveness of the roles themselves. This goal of good health is particularly ironic in the light of the fact that the word health originally meant whole, W-H-O-L-E. As defined by the medical model, health values come to mean partial solutions which go against total integrity of the body, the individual concerned, and society in general. The proponents of the medical model who have extolled the professional goal of therapy have given themselves the mandate to manipulate in the interest of reduced suffering for the transsexual. And in doing so, they have forced transsexuals back into a social system whose basic sexist norms and values remain unquestioned. Many persons express the urgency of their desire to be transsexed in terms of normalizing their self-perceived masculine or feminine psyche in a male or female body. The abhorrence of homosexuality expressed by many transsexuals and their unwillingness to be identified as such indicate their desire to normalize their sexual relationships as heterosexual by acquiring the appropriate genitalia. Many express also their desire to be married, have adopted children, and function as part of a society where these roles and functions are both normal and normative. Thus, the transsexual is generally no advocate of social criticism and change. The medical model itself promotes this so-called normalization, and in doing so, limits the quest for self-transcendence. The kinds of health values it generates do not encourage the transsexual to recognize that such health may be unhealthy in the long run. Quote, "Health values are all of a piece again with our philosophy of adjustment, spurious individualism, and unashamed and thoughtless self-seeking." End quote. Such notions of health make true individualism and autonomy unachievable, rendering the individual passive, acquiescent, and medically manipulable. They deprive the individual of the possibility of transcendent activity and center him or her on false goods, gods. As Philip Reeve has said, quote, "By this time, men have gone too far beyond the old deception of good and evil to specialize at last wittingly in techniques that are to be called therapeutic, with nothing at stake beyond a manipulable sense of well-being." End quote. The presence of counseling and treatment of transsexuals based on the medical model I have described give the transsexual no real moral options. Failing to analyze our society's definitions of masculinity and femininity, such therapy offers little encouragement and advice to help the transsexual live beyond both these containers of personhood. Consider the possibility of counseling that encouraged the transsexual to break both stereotypes. Here, the transsexual would be encouraged to become the agent of her or his own energies and to strive for more varied modes of being and becoming. In a very real sense, at this point, the transsexual would become a social critic. All of us are in some way constricted by sex role socialization. One way of viewing transsexuals is that they are uniquely constricted by the rigidified definitions of masculinity and femininity. The general cultural constrictions from which we all suffer become body-laden with them. However, deprived of an alternative framework in which to view the problem, the transsexual is unable to express the problem clearly. The gender identity clinics have a vested interest in suppressing criticism and may collude with the transsexual to solve the problem in an ultimately uncritical way. Given a different mode of therapy where consciousness raising is the primary modus operandi, the transsexual might not find it as necessary to resort to sex conversion surgery. Footnote: there is no simple definition of consciousness raising, which will be discussed in the appendix. Briefly, and in this context, It can be defined as a mode of counseling that places so-called personal problems within the larger arena of patriarchal society. At the heart of such a process is the recognition that the personal is political. End footnote. Back to main text. A society that encourages identity and role conformity based on biological sex will naturally turn to sex conversion surgery rather than accept what it sees as a threatened obliteration of these roles. Until the problems that psychiatry has claimed for itself are broadened into a general criticism of patriarchal society, transsexualism will not be understood as a medical manipulation of social and individual action and meanings. Meanwhile, the medical model and its empire continue to domesticate the revolutionary potential of transsexuals. The potential stance of the transsexual as outsider to the conventional roles of masculinity and femininity is short-circuited. Health values and goals hide the possibility from transsexuals themselves of being history-bearing individuals who, instead of conforming to sex roles, are in a unique position to turn their gender agony into an effective protest against the very social structures and roles that spawned the dilemma to begin with. Reeve has pointed out that therapies, and by extension, I would say the medical model in general, consists chiefly in participation, mystiques severely limiting deviant initiatives. Individuals are trained through what Reeve calls ritual action to express fixed wants. The limitation of possibilities is the very design of salvation. Thus, being is reduced to well-being therapy, and ethical choices are reduced to health values. The de-ethicization of problems and behavior. One of the major effects of the medical model has been the de-ethicization of problems and behavior. De-ethicization occurs when problems that have moral implications are defined as if they had none, or are redefined or reclassified, for example, as therapeutic considerations, or health issues, or psychiatric management problems. The triumph of the therapeutic has made transsexualism the territorial imperative of the psychologist, psychiatrist, and/or mental health worker. Thomas Szasz has noted that the conquest of human existence by the mental health profession started with the identification and classification of so-called mental illnesses, and has culminated in our day with the claim that, quote, all of life is a psychiatric problem for behavioral science to solve, end quote. Szasz has attempted to show that persons, by seeking relief from the burden of what are technically moral responsibilities, mystifies and technicize their problems in living. In turn, this hunger for help and health is fed by a behavioral technology ready and willing to free such persons of their moral burdens. Indeed, Szasz contends that the mandate of the contemporary psychiatrist is precisely to obscure, and moreover to deny, the ethical dilemmas of life, and to transform these into medical and technical problems susceptible to their solutions. In the same way, transsexualism has been categorized as a medical and technical problem that is only resolvable by medical and technical specialties. Mystification is at work throughout the transsexual odyssey. It operates in a variety of areas, in the claim that one is, for example, a man trapped in a woman's body, in the obscuring of the social components of the problem, in the hidden political dimensions of therapy, in the various individualized explanations, and in the very language of transsexualism itself. As demonstrated earlier, it is biologically impossible to change chromosomal sex, and thus the transsexual is not really transsexed. As Dr. Georges Borot, a French physician who specializes in male-to-constructed female transsexualism, phrases it, quote, I don't change men into women. I transform male genitals into genitals that have a female aspect. All the rest is in the patient's mind, end quote. Or, as Jan Morris inadvertently stated, quote, I wear the body of a woman, end quote. De-ethicization, of course, is defended in the name of scientific knowledge and neutrality. However, neutrality is a myth, and the politics of diagnosis and therapy remain. So too do the philosophical, ethical dimensions of the psychological craft. Under the guise of science, psychological explanations often include value judgments. For example, when John Money and Patricia Tucker assert, quote, "Once a sex distinction has worked or been pressured into the nuclear core of your gender schema, to dislodge it is to threaten you as an individual with destruction," end quote. They are using popularized pseudoscientific language where the oughts have been deleted, yet where they permeate the sentence. Thus, the reader translates, quote, "Once a sex distinction has worked or been pressured into the nuclear core of your gender schema, one should not dislodge it, else the individual is threatened with destruction," end quote. One might also ask here, destruction by whom? By what? Once more, the agent is deleted. The process of the de-ethicization of behavior by psychology and psychiatry has particular relevance for discussions of transsexualism and the consequences which follow. By attributing transsexualism to biological or psychological causes, scientists, as stated previously, are conveying that there are only two choices: one, adjustment to one's body role, or two, surgery and counseling to transform one's body and role. In effect, both of these choices are biomedical. Choice number one adds up to biology is destiny, and choice number two states that, this failing, hormonal and possibly surgical treatment, contingent upon one's passing, of course, are indicated. Either way, the transsexual cannot really make an ethical choice because there are no choices to make. The only choices represented are those that biomedicine dictates in this culture. The wider range of choices and the discovery of meanings that would be available to one who could live beyond sex roles, but in one's native body, are not made available. Such reductionism and restricted counseling fetishize the transsexual issue. Therapeutic fetishization. In discussing the various theories of transsexualism, I often noted that both biological and psychological theories reduce the issue of transsexualism to individual or interpersonal causes. Another way of viewing this, and thus understanding the reductionism more clearly, is to consider these theories as fetishizations of the social. Not only the theories, but the whole gamut of psychologizing restrict the issue to a very superficial area. Ernest Becker, in The Structure of Evil, discusses the function of fetishization. He views it as an attempt, in some manageable way, to come to grips with a portion of reality which is substituted for the whole. Fetishization, for example, is one explanation why law enforcement officials in our society are so obsessed with issues of traffic violations, marijuana, and the like, but cannot cope with the much more serious problems of rape and murder. As Becker contends, the lesser problems and the attention they received are social fetishizations of the problem of morality in modern times. In the case of transsexualism, it would be an overwhelming burden to attack the problem of sex role socialization on an individual, never mind social, level. Therefore, it is easier applying a fetishized logic to confront the problem within patriarchal identity and role limits, thereby making use of a ready-made system of knowledge and therapy that treats the problem individually on a post hoc basis. Moreover, the fetish object is precisely the one that presents itself to our eyes in the most striking and compelling way. Obviously, in the case of transsexualism, that which is most directly and immediately expressed, from the perspective of the transsexual especially, is the feeling/knowledge that one is a woman trapped in the body of a man. Subsequent behavior and dress reinforce this felt identity and role. Evaluating whether or not a transsexual can pass successfully in the role of his or her desired sex monopolizes the attention and energies of those professionals in the gender identity clinics who should be evaluating the culturally prescribed roles themselves. In the same context, the reality of transsexualism is explained by the supposed effectiveness of sex conversion surgery as the ultimate cure. These are all examples of what Becker calls fetishizing the field, or, quote, creating a locus of meaning in a very narrow sense in order to be able to have some reality that calls upon one's adaptive energies, end quote. Transsexuals and transsexual experts focus on the genitalia of the opposite sex, the desired breast and vagina, or the construction of an artificial phallus. These artifacts come to incarnate the essence of femaleness or maleness, which the transsexual so urgently desires. The medical literature on transsexualism is filled with photographs, plates, and anatomical drawings of sexual organs that have been constructed onto the post-operative transsexual in such a way as to highlight the natural look that the knife has wrought. Interestingly, these photographs seldom show the whole person. With a zoom lens effect, they center upon the breast or phallus. Thus, the photographs themselves illustrate the fetishizing of transsexualism. The medical surgical solution begins to assert control in the narrow area of the chemical and surgical specialties. Attention becomes focused upon the construction of the vagina, for example, in as aesthetic a way as possible. What Becker amplified in his discussion of fetishism, Seymour Halleck discusses under the heading of the politics of symptoms. Halleck points out that treatment which focuses on symptoms rather than a broad social or existential issues is very likely to be efficient. In the case of transsexualism, we see that 90% of transsexuals report satisfaction post-operatively. However, as Halleck explained, this kind of satisfaction is achieved at the expense of exploring the social meaning of the symptoms. By the instrumentality of hormones and surgery, the symptom is certainly removed, but so is the indirect evidence provided by the symptom that something is amiss on a deeper level. Therefore, after medical intervention, transsexuals may have less power to cope with the forces of oppression than before they started treatment, since at this point they fit into a role-defined world almost completely. Any critical awareness is thus diffused. Since the result of hormonal and surgical treatment is that the transsexual becomes an agreeable participant in a society which encourages sexism, primarily by sex role oppression, then the moral and political implications of that treatment must be questioned. In this sense, transsexual surgery is a social tranquilizer. For the sake of health and well-being, the status quo of patriarchy is strengthened. The politics of transsexual therapy. Value freedom and political neutrality have long been advocated in psychiatry and the professions in general. But Seymour Halleck, in 1971, asserted what is by now a commonplace, that any kind of psychiatric or counseling intervention will have an impact upon the distribution of power in society. Psychiatric neutrality in this perspective is a fiction. Implicit in Halleck's position, of course, is the assertion that the psychiatrist or counselor is a social engineer, because any counselor has some preconceived ideas of what is good for people, whether these be implicit or explicit. Such values are transmitted to the person seeking help. Whatever route the counselor goes, she or he will either encourage the person to accept or to change the existing distribution of power. As Halleck further points out, there is a strange tendency among counseling professionals to assume that any counseling intervention that is not explicitly political or that does not change the status quo is neutral, whereas any professional activity that is explicitly change-oriented is designated as political. Sass formulates this same idea in a somewhat different way, emphasizing the social and ethical dimensions of a counselor's therapeutic stance. Quote, difficulties in human relations can be analyzed, interpreted, and given meaning only within specific social and ethical contexts. Accordingly, the psychiatrist's social ethical orientation will influence his ideas on what is wrong with the patient, on what deserves comment or interpretation, in what direction change might be desirable, and so forth. End quote. In our society, political power is based on sex. Kate Millett stated this most effectively back in 1970 in her work aptly titled Sexual Politics. By politics, she does not mean the word in the narrow sense, but is referring to, quote, power-structured relationships, arrangements whereby one group of persons is controlled by another, end quote. The title, Sexual Politics, implies that the sex into which one is born, and all that goes with biological maleness or femaleness, create a category with political implications. The personal is recognized as political. The personal interaction between women and men is thereby seen to be political. Quote, what goes largely unexamined, often even unacknowledged, yet is institutionalized nonetheless, in our social order, is the birthright priority whereby males rule females. Through this system, a most ingenious form of interior colonization has been achieved. It is one which tends to be sturdier than any form of segregation and more rigorous than class stratification, more uniform, certainly more enduring. However, its present appearance may be, sexual dominion, obtains nevertheless as perhaps the most pervasive ideology of our culture and provides its most fundamental concept of power. End quote. Whereas any therapy affects the distribution of power in society, the relationship between transsexualism and sexual politics is a unique one. The encouragement that is given to transsexuals in therapy to conform to society's roles of masculinity and femininity supports the very bulwark of sexual politics, that is, sexual socialization. Furthermore, such therapy is not only political but morally manipulative. Therapy not only affects the distribution of power, but also brings about the alteration of values. What we have here is a very sophisticated form of behavior control and modification on both the individual and social level. Transsexualism as behavior control and modification. Transsexualism, as a proclaimed form of therapeutic surgery for non-physical disorders, is located on a historical continuum of similar medical ventures, all of which legitimate bodily intervention for the purposes of improving behavior. In the 19th century, clitoridectomy for girls and women, and to a lesser extent circumcision for boys, were accepted methods of treatment for masturbation and other so-called sexual disorders. In the 1930s, Egas Moniz, a Portuguese physician, received the Nobel Prize for his groundbreaking work on lobotomies. Moniz operated on state mental hospital inmates using lobotomy for everything from depression to aggression. The new terminology for brain surgery of this nature today is psychosurgery, which its proponents have attempted to disassociate from the cruder procedures of Moniz and others by pointing to its more refined surgical techniques. But call it lobotomy or psychosurgery, surgeons continue to intrude upon human brains on the basis of tenuous localization theories that supposedly pinpoint the area of the brain where the undesirable behavior can be found and excised. Finally, transsexual surgery is justified on the basis of adjusting a person's body to his/her mind. What each of these surgical ventures has in common is that they derive their therapeutic legitimacy from a medical model which locates behavioral problems within certain affected organs. Surgery then alters, intrudes, removes, and in the case of transsexualism, adds organs. In each venture, a surgical fetishizing takes place, reducing the social components of the problem to the most tangible and manageable forms. Further, what each of these surgical ventures has in common is the modification and control of behavior. Clitoridectomies modify sexual behavior or fantasized sexual behavior. Psychosurgery modifies the gamut of behavior from hyperactivity in preteen children to so-called manic depression in dissatisfied housewives. Transsexual surgery modifies everything that comes under the heading of masculine and feminine in a patriarchal society, thus practically everything. In the case of transsexualism, behavior modification is both a prerequisite for and an effect of the surgery. Prior to the operation, gender identity clinics and professionals require that transsexuals alter their behavior to conform to the prescribed gender role the person desiring transsexual surgery wants. In this context, it can also be pointed out that sex role conditioning itself is a form of social control, i.e., the control that a patriarchal society exercises over its members. Yet, with a good number of people, this form of social control has been unsuccessful. This has happened with the transsexual who has not been adequately conditioned into the role/identity that accompanies his or her body. Instead of seeing this unsuccessful conditioning and gender dissatisfaction as a signal of transcendence, however, the transsexual seeks out, with the help of the transsexual technicians, another mode of behavior modification, which is transsexual treatment and surgery. This latter form of behavior modification and control then reinforces for the transsexual, in several hormonal and surgical strokes, the behavior that took years of sex role conditioning to impose upon persons who belong to the sex that the transsexual desires. Thus, we have a multiplication of modes of behavior modification. 1. Sex role conditioning that accompanies a male or female body and which, in the case of the transsexual, fails. 2. Sex role reconditioning, which accompanies and is prerequisite for the body that the transsexual seeks and which the transsexual technicians, psychological and surgical, encourage and reinforce. 3. Transsexual treatment and surgery which solidify the pre-surgical conditioning. Reinforcement is a key word for a behaviorist. One of the central claims of B.F. Skinner is that the immediacy of reinforcement is what shapes successive behavior in all learning animals. Skinner differs from classical conditioning theorists, e.g. Pavlov, in saying that behavior is shaped by what follows it rather than by what precedes it. In the past, most psychologists of this persuasion had assumed that new attitudes were necessary to develop new behavior. Skinner turned this around and said that new attitudes follow or accompany changed behavior. In the case of the male to constructed female, transsexual, however, feminine behavior is shaped by the promise of what is to follow. That is, a changed body. Encouraged by the gender identity clinics to prove transsexual status by their ability to pass as feminine, transsexuals seek hormone treatments and ultimately sex conversion surgery as positive reinforcement of further stereotypical behavior. Thus, transsexual counseling in clinics are a very good example of Skinner's operant conditioning philosophy. The controller, using a series of carefully planned schedules of positive and or negative reinforcements, shortening or lengthening the passing time, brings about desired responses, stereotypical behavior, from the transsexual. However, the most significant point in Skinner's philosophy is that the controller will exert hardly any control because the controlled will control themselves voluntarily. Coercion, in the traditional sense, will not have to be employed. Skinner creates a utopia where people will to live. Somewhat contradictorily, however, freedom is a mentalist concept in the Skinnerian scheme. It is clear that voluntarism is a very deceptive construct in the behaviorist framework. In like manner, the concept of voluntarism is deceptively highlighted in the transsexual literature. Sex conversion surgery is not forced upon transsexuals. The transsexual researchers and clinicians emphasize that persons who desire to change sex seek such treatment eagerly. Like the benevolent behaviorism in Skinner, transsexual surgery is presented as something thousands request, many of whom are turned away. To use another example, many oppressed people use heroin to make life tolerable in intolerable conditions. Heroin usage is a highly effective yet dangerous treatment for dissatisfaction and despair. Recently, for example, Black leaders have drawn attention to heroin as a pacifier of Black people. As Jesse Jackson has phrased it, quote, "We have come from the southern rope to the northern dope," end quote. In a strict sense, one cannot say that the drug is forced upon its users. Indeed, they seek it eagerly. But in the long run, the willing use of the drug strengthens the position of the oppressors and the oppressed. The contentment and euphoria produced by the drug diffuses the militancy or potential militancy of the user. Thus, heroin is a tool of behavior control and modification. Transsexual surgery, in much the same way, produces satisfaction and relief for the transsexual, in contrast to more overt coercive forms of behavior control and modification, such as involuntary commitment in prisons or mental institutions, or informed consent obtained while in these same institutions. Transsexualism appears to be blissfully and freefully chosen. Yet, just as commentators have asked how a truly informed consent can be obtained in a coercive context, such as a prison or mental institution, I would pose the question, how can transsexuals truly give informed consent and freely choose to convert to the opposite sex anatomy and role when the coercive power of sex role socialization is filtered through all institutions in a patriarchal society? Not that such socialization is deterministic, but rather it deeply conditions one's choices as well as one's motivation to choose. In a traditional sense, no one forced the transsexual to change sex. No one forced the transsexual to start hormone therapy. No one forced the transsexual into opposite sex roles and behavior. But in a society where masculinity and femininity accompany a male or female body, the options are limited if one does not have a context of support to transcend these roles. When the transsexual experts maintain that they use transsexual procedures only with people who ask for them, and who prove that they can pass, they obscure the social reality. Given patriarchy's prescription that one must be either masculine or feminine, free choice is conditioned. What is significant here is that either way, by outright coercion or by employing an individual's voluntarism against herself or himself, the coercive impact is the same. As Willard Galen has noted in a different context, quote, "It's society's coercive impact, incidentally, is just as great whether it was designed to produce the effect or whether the effect was an accidental, historic, and developmental spin-off," end quote. We are at a point in the history of behavior control and modification where we must be very aware of its more subtle forms. Most people recognize the manipulation of human behavior and emotions at its most extreme, when that manipulation is organized or when physical agents are used. Many people, however, would not perceive transsexual surgery as a form of behavior control and modification, even though physical instrumentation is used, because the concept of voluntarism has taken hold, and the coercion of a role-defined environment is not recognized as an influential factor. Furthermore, quote, "It may be that the general population resists the idea of seeing emotional coercion in the same terms as physical coercion because it threatens basic beliefs about man's autonomy, because one likes to think of himself as a logical individual under the control of intellect rather than emotion," end quote. But, of course, social controllers have been well known for convincing the individual that she/he is in control. Thus, it is important, in the transsexual context, to examine the whole of the issue of control. Who is controlling whom? Presently, the controllers are the gender identity clinics and the transsexual experts who staff them. It is not far-fetched to conceive of a gender identity business, as such institutions proliferate, functioning as centers of social control. We now have violence control centers, such as Vacaville, which, in the words of its main organizer, has been designed to focus on the pathologically violent individual and is aimed at altering undesirable behavior. As the gender identity clinics expand and the tolerance for transsexual surgery grows, it is not inconceivable that such clinics could become sex role control centers for deviant, non-feminine females and non-masculine males, as well as for transsexuals. Such gender identity centers are already being used for the treatment of designated child transsexuals. The use of behavior modification and control is presently very widespread. It is fast becoming a tool of American law enforcement, and funding for it from state and government sources has been well documented. Furthermore, we can safely predict, on the basis of past and present CIA and FBI activities, that if gender identity facilities become government-controlled, some gender modification activities would be reported, while others would be repressed from public view. Only those offering a therapeutic rationale would be revealed. Moreover, such controllers and centers for control, such as Johns Hopkins and UCLA, would continue to have very specific philosophy about what women and men should be, how they should act, and what functions they should perform in society. In fact, gender identity clinic research and treatment has already been funded by grants from the National Institute of Mental Health and other government-affiliated funding sources. All of this is happening and will continue to happen, of course, in the name of science and therapy. And with the denial that any social engineering is taking place, here we have institutional sexism at its most functional capacity. A dystopian perspective, some will say, but such perspectives have a way of highlighting present and future reality by daring to predict what most persons do not or choose not to perceive. The point is that sex roles already do not have to be forced upon people. Most quickly give informed consent. But feminism has been fast chipping away at the institutions of sex role conditioning in this society. Threatened commentators from a patriarchal perspective have been quick to call feminism sexual suicide. Just as doctors Vernon Mark, William Sweet, and Frank Irvin suggested in the Journal of the American Medical Association that psychotechnology could be used for the repression of violence in the Detroit Ghetto Rebellion of 1967. It is not inconceivable that doctors X, Y, and Z could propose sexual technology for the repression of sexual deviancy. It has been done before, e.g., clitoridectomies, and it can be done again. It would all be part and parcel of present voluntaristic therapies for the repression of deviancy. Individuals undergo psychosurgery given informed consent, Parents, on advice of school administrators and physicians, signed informed consent papers to have Ritalin administered to their children in public school centers. Women consentingly undergo unnecessary hysterectomies for prophylactic reasons such as the vague threat of uterine cancer. Imagine a prophylactic penectomy. The potential for the benevolent control of sexual behavior is enormous. It is my contention that it has already begun in the gender identity clinics, but control here has entered with a whimper, not a bang, and conformity is being enforced in the name of therapy, at the individual's request, and with the effect of 90% satisfied customers. If behaviorist philosophers such as B.F. Skinner are right, and behaviorist technicians such as Jose Delgado remains active, then future social controllers can replace control through torture with control through pleasure. What is becoming possible with Delgado's electronic brain stimulation, ESB, is also becoming possible with transsexual surgery. The following two observations are not all that different. From Delgado, quote, "Electrodes were implanted in her right temporal lobe, and upon stimulation of a contact located in the superior part about 30 millimeters below the surface, the patient reported a pleasant tingling sensation in the left side of her body, from my face down to the bottom of my legs. She started giggling and making funny comments stating that she enjoyed the sensation very much. Repetition of these stimulations made the patients more communicative and flirtatious, and she ended by openly expressing her desire to marry the therapist. The second patient expressed her fondness for the therapist, who was new to her, kissed his hands, and talked about her immense gratitude for what was being done to her." End quote. And in the case of transsexuals, quote, "Typical comments after the operation include feelings of deep satisfaction at having achieved, as they felt, true female status, despite admission that they were in fact only castrated, feminized males. They reported an absence of self-consciousness and a feeling of being at ease and having ultimately achieved a happy state with more peace of mind. Increased feelings of femininity occurred along with the development of a sense of identity with all women. They began to think of themselves as women rather than disabled males. The fear of detection and the fear of being suspected disappeared despite the fact that several were not entirely credible as females. Several described a sense of release and a change of mental attitude. They felt that it was now impossible to prove they were not women. Most expressed a level of satisfaction in their newly castrated status far superior to anything they had experienced as men. Acceptance as women by other women and by the world at large was their ultimate satisfaction. The possession of a female vulva was of secondary importance to this." End quote. In both examples, we see expressions of sweet, intense, and protracted satisfaction, or, as one commentator has called it, total body orgasm. Humans have been known to withstand even the most intense torture. It is doubtful, however, that we could withstand the most intense pleasure. Footnote. Adrienne Rich has suggested, in contrast to this interpretation, that what really happens is that control works through the controller's power to cut off pleasure at any point, rather than through his power to confer pleasure. She also points out that there is a social situation of pleasure to which persons are conditioned. For example, a woman who is socialized to identify orgasmic pleasure with being handled and controlled by a man will more easily be stimulated to pleasure by electrode brain implants than a woman whose social situation of pleasure does not include such handling and control. What Rich is saying is that for such women, ESB would not be pleasurable in any sense they could identify as free human beings. End footnote. Back to main text. As William Irwin Thompson has noted, quote, "If the momentary total orgasm experienced when a drug addict injects methadone is sufficient to alter the personality, then it is obvious that a total body orgasm protracted over a period of hours or days would be sufficient to alter a person's perception of time, his perception of his own life history, and the self-image and character structure derived from these. From the point of view of the behavioral scientists, this would be pleasant work in what could be amenable surroundings, end quote. The transsexual counselors and technicians' apparent purpose, of course, is neither to control nor to create massage parlors of pleasure, but to provide therapeutic relief for those persons who feel themselves burdened with the wrong mind and the wrong body. However, the final irony, as Thompson has stated, is that at the end of humanism, it is the human body that has become the battleground. I would add further than the real final irony is that at the nemesis of patriarchal civilization, all the silicone breasts and artificial vaginas cannot put man back together again. Transsexualism as medical experimentation. Therapy has historically covered a multitude of medical sins. The welfare of the individual or the welfare of society has often provided a camouflage for the worst forms of experimentation. We have seen how therapy relates to behavior control and modification. What also becomes obvious is that therapeutic goals can mask experimentation. First of all, the nature of transsexual surgery is experimental on the physical grounds alone. There is a substantial amount of evidence that transsexual hormone therapy and surgery cause cancer. Transsexual treatment is far from established as safe medical procedure, and as such is still experimental. Secondly, transsexuals are volunteering for surgery that they hope will relieve their sexual disease of gender dissatisfaction and dysphoria. But there is no evidence to prove that transsexual surgery cures what is basically a problem of transcendence. In other words, sex conversion surgery cannot bestow upon the transsexual the sense of self that he lacks. Furthermore, there is evidence, at least in some post-operative cases, that transsexuals themselves have come to realize this, but too late. Third, and most importantly, we have yet to see the total fallout effect of transsexualism in enforcing the further institutionalization of sex roles. Until this is obvious, transsexual surgery is still experimental in terms of what effects it will have upon an already rigidly gender-defined society. And if it is true that the female deconstructed male transsexual is merely a token who provides the illusion of inclusion of women into transsexual context, then one hypothesis that is being tested in the transsexual laboratories is whether or not it is possible for men to diminish the number of women in order to create a new breed of females. Again, I would emphasize that this is not a mere feminist flight of fantasy. Scientists have already stated their scientific interest in diminishing the numbers of women. Take, for example, the words of the well-known biologist John Postgate in his ringing defense of sex selection technology. Postgate defends what he calls a male child pill by offering it as a proposed panacea for world population problems. In words that, upon first reading, appear to be satire, we quickly come to realize that Postgate is deadly serious, deadly to women, that is. Quote, "Imagine what would happen if a male child pill became freely available throughout the world through the World Health Organization. Even in developed countries, there is surprising prejudice among ordinary people in favor of having male children. Among most African, Asian, Central, and South American peoples, this prejudice amounts to an almost obsession. Countless millions of people would leap at the opportunity to breed male. No compulsion or even propaganda would be needed to encourage its use. Only evidence of success by example. I hope, incidentally, that it is obvious why I specified a man-child pill. One selecting for females would not work." End quote. As far as the leftover women would be concerned, Postgate has thought of everything. Quote, "All sorts of taboos would be expected, and it is probable that a form of purdah will become necessary. women's right to work, even to travel alone freely, would probably be forgotten transiently. Polyandry might well become accepted in some societies. Some might treat their women as queen ants, others as rewards for the most outstanding or most determined males. Whether the world would come to resemble a giant boys' public school or a huge male prison is difficult to predict. End quote. Finally, the social results and economic consequences of all this, Postgate predicts, would be self-regulating. Some of the ethical issues that have been discussed in the biomedical literature on human experimentation take a different turn when applied to transsexuals. One issue that recurs in the literature on human experimentation again and again is that of weighing the integrity of an individual experimentee's rights against the benefits that may accrue to society. This issue has often been discussed in the context of an individual who risks her or his health in an experiment designed to acquire knowledge about a specific disease, thereby benefiting society, but not necessarily directly benefiting the individual concerned. However, there is a reversal of these priorities in the transsexual situation, which focuses on the alleged benefits that accrue to the individual. In this instance, it is the ill effects that accrue to society that must be questioned. Transsexual surgery is professedly done to promote the individual transsexual's right of synchronizing body and mind. Yet what society gains is a role-conformist person who reinforces sex roles. Pleasure and pain, medical theodicies. A second issue that has been discussed in the wider medical context of human experimentation is whether medicine is obliged to alleviate all suffering, that is, whether it should make the world disease-free. In the case of transsexualism, there are many ethical objections to alleviating individual gender suffering at the expense of reinforcing qualitatively and quantitatively sex role conformity. Ivan Illich's words are applicable. Quote, medical civilization teaches that suffering is unnecessary because pain can be technically eliminated. The subject is better understood when the social situation in which pain occurs is included in the explanation of pain. End quote. However, my main point has been to show that social situation has not been included in the explanation of pain. Instead, transsexual technicians and therapists, and by extension transsexuals, engage in smothering the intrinsic question mark that gender disease produces about the society in which it arises. Medical theodicies, however, unlike many religious ones, are not passive, but proclaimedly curative. One's reward is not in the next life, but in this life. The ethic is reversed. Do not suffer now, but seek ye another body. The activity of this medical theodicy involves several steps. First of all, the transsexual therapists relate the anomic experiences of the gender dissatisfied individual to a condition known as transsexualism. Once named and institutionalized, in gender identity clinics, the condition of transsexualism explains why one would have the wrong mind and the wrong body. Secondly, like all theodicies, the medical theodicy is undergirded by an attitude of the surrender of the self to the ordering power of the transsexual therapists and technicians. The medical order confronts transsexuals with a meaningful reality that comprehends them in all their experiences. It bestows sense on all their experiences that once seemed so unfathomable. It enables someone like Jan Morris to order in chronological fashion the steps in his transsexual odyssey from the age of 3, when he first realized he was a woman, as he sat under his mother's piano listening to Sibelius, to his conquest of Mount Everest, and last, fling with masculinity. As Peter Berger has noted, quote, the individual who adequately internalizes these meanings at the same time transcends himself. His birth, the various stages of his biography may now be interpreted by him in a manner that transcends the unique place of these phenomena in his experience. End quote. More importantly, the denial and surrender of the self is facilitated by the transsexual order. Quote, "This is the attitude of masochism, that is, the attitude in which the individual reduces himself to an inert and thing-like object vis-a-vis his fellow men. In this attitude, pain itself, physical or mental, serves to ratify the denial of self to the point where it may actually be subjectively pleasurable." End quote. What has been scarcely noted in many commentaries on transsexualism is the immense amount of physical pain that the surgery entails. Generally, this fact is totally minimized. Most post-operative transsexuals interviewed seldom commented on the amount of physical pain connected with their surgery. Are we to suppose no pain is involved? Anyone who has the slightest degree of medical knowledge knows that penectomies, mastectomies, hysterectomies, vaginoplasties, mammoplasties, and the like cannot be painless for those who undergo them. There is also the pain of anxiety about the possible consequence of surgery, such as cancer or faulty healing. It seems that the silence regarding physical pain on the part of the transsexual can be explained only by an attitude of masochism, where one of the key elements of the transsexual order is indeed the denial not only of self but of physical pain to the point where, quote, "it may actually be subjectively pleasurable," end quote, or at least subjectively negligible. At least one medical team has recognized this, although in muted and partial form, categorizing primary clinical types who request sex reassignment. They label one type as masochist or sadomasochist. Quote, "The masochists find that sexual arousal is facilitated by the experience of pain prior to sexual activity. They look upon the surgical excision of the genitalia, albeit unconsciously, as a form of masochistic adventure with the surgeon." End quote. Ernest Becker has stated that masochism is another word for poverty of behavior, as is sadism. Quote, "The sadomasochist is someone who has trouble believing in the validity and sanctity of other people's insides, their spirit, personality, or self. These insides could be his own or others. If they are his own, he tends to be masochistic. If they are others, he tends to be called a sadist." End quote. Transsexuals, as masochists, have great difficulty in believing in the validity and sanctity of their own insides. They are attempting to gain a sense of self not only through the acquisition of a new body, but through the pain involved in this process. Physical pain is a constant reminder to transsexuals that they are finally coming alive. In the transsexual's quest for what may be regarded as a deeper self, pain provides the illusion of profound change. Pain is necessary to confirm what is regarded by the transsexual as more than a superficial change. This, in one way, explains why transsexuals do not settle for cross-dressing. Transvestism, for them, is too superficial and does not provide the bite or the painful experience of true conversion. Transsexuals, in their experience of pain, feel they have thus reached the essence of female or male existence. There is also an element of sadism, which is, of course, the other side of the masochistic coin. Quote, "The aesthetics of the sadist is thus partly due to the deficiencies of his own self. In order for reality to be convincing, in order for him to feel his maximum powers, he wants the world to be peopled with concrete, manipulatable objects, with objects that do not have any elusive insides. This is the reason that he expends all his effort on manipulating the flesh. Either he cannot deal with the insides of others, or he will not recognize these insides as valid." End quote. The transsexual therapist, in adjusting the transsexual mind and behavior to the stereotype of the desired sex, and the medical specialist, in adjusting the transsexual body to the desired body type of the opposite sex, are dealing with transsexuals as manipulable objects and reducing them to the world of appearances. Quote, "Here we can understand the interchangeability of the sadistic and masochistic postures. These are terms which describe one and the same thing: weakness and felt limitation in oneself, sharp duality of spirit and matter in people." End quote. The sadist, as well as the masochist, cannot relate to the infinite possibilities of the spirit and confines these spiritual possibilities to the world of matter. Thus, the potentiality for infinite being is reduced to static being, where it can be rendered safe and deprived of its power to transform the gender-defined self and the gender-defined society. It is in this way that religious theodicies have restricted not only the selfhood but the social protest capacity of their believers. In doing so, of course, they have also directly legitimated the institutional order in question. As Berger has noted, quote, "The theodicy constitutes an essentially sadomasochistic collusion on the level of meaning between oppressors and victims." End quote. On both sides, the result is one of world maintenance, and in the transsexual context, the maintenance of the particular institutional order of patriarchal society. A not-so-incidental byproduct of this particular medical theodicy is the enlargement of medical knowledge about manipulating organs of the body which specifically function to define biological sex. This, of course, works to the ultimate benefit of the sadistic side of the theodicy, enabling medical research and technology to acquire a specialized body of scientific knowledge on the manipulation of human sexuality that probably could not be acquired by any other accepted medical procedure. At least 2 researchers have admitted this, although the admissions, of course, are mixed with therapeutic qualification. Richard Green has stated, quote, "To a considerable degree, the medical profession itself is responsible for the limited extent of knowledge which currently exists about transsexualism and sex reassignment. While the current availability of gonadal hormones and the refinement of surgical techniques have made it possible to partly realize the fantasies and aspirations of the transsexual, and have brought about an increasing demand for sex reassignment, medicine, by closing the door to these patients for study and treatment, has cast away a population from whom considerable information about gender identity and human sexuality could have been obtained. Particularly in the United States, until very recently, sex reassignment has been nearly unobtainable. Thus, transsexuals sought treatment elsewhere. Consequently, neither the preoperative screening nor the postoperative evaluations were made. Rejection of the transsexual's request, rather than preventing him from obtaining surgery, resulted in the highly motivated, affluent patient still being able to obtain his reassignment, but in the process, being virtually lost to scientific study." End quote. In a similar manner, Milton Egerton has stated, quote, "The current availability of reputable physician teams who offer sincere efforts to understand and treat the transsexual patient may represent the greatest progress that medicine has made over the past decade in dealing with human gender disorders. Certainly, it offers doctors an unrivaled opportunity to study and understand the dynamics of gender as it relates to human function and self-imagery. Plastic surgeons are beginning to realize that it is more important to correct the patient's sense of deformity or self-image than to correct his external or objective deformity." End quote. Thus, transsexualism is made to appear as an acceptable medical venture in which scientific opportunism is admitted, but only as linked to therapeutic and humanitarian goals. A third issue to consider is just how informed consent can be attained, especially in the face of so many unknown hazards about the experiment. First of all, a truly informed consent would highlight, for the transsexual, the whole issue of sex roles and gender definitions themselves. It would reveal to him how moving from one stereotype to its opposite does not even minimally alter the social basis of sexual conformity in this culture, and how the transsexual, in undertaking surgery, is reinforcing this conformity. These are what might be called the social hazards of the transsexual experiment. My survey of the literature and first-hand interviews with transsexuals and transsexual clinicians thus far have revealed that these social hazards, or even their possibility, are not explored. Furthermore, it has generally been recognized that the withholding or distortion of any relevant knowledge that bears upon the experiment constitutes a violation of informed consent. It is questionable whether even the physical hazards of transsexual treatment and surgery are explained to the would-be transsexual. Finally, the issue of informed consent enters again in the context of the ethics of experimentation. Discussions on medical experimentation have focused on the question of whether a truly informed consent can ever be obtained from a captive population. As I have shown, transsexuals are just such a captive population within a patriarchal society. Otto Gutentag has written, quote, "It is generally agreed in our culture, experimental subjects must be volunteers. What is meant by the word is, first, that the experimental subjects who agree to volunteer are judged by society as free in the psychological sense, as experiencing themselves ultimately as centers of autonomy, whatever the contingencies, and second, that they are free in the sociological sense, that is, not dependent upon the experimenter to satisfy their spiritual or physical needs." End quote. First of all, how are would-be transsexuals free in the psychological sense? How can they be ultimately centers of autonomy if their motivation to choose differently is held captive by a patriarchal society, so that even what they finally do choose, i.e. transsexual surgery, binds them even more firmly to that society? Secondly, how are transsexuals free in the sociological sense, when indeed they do depend upon the experimenters to satisfy their spiritual needs, the conviction and fulfillment of, for example, finally becoming a woman, and physical needs, acquiring the hormones and body of a woman? Learning from the Nazi experience. Much of the literature on medical experimentation has focused on the various captive populations of prisoners and mental patients, but the most notorious example of unethical medical experimentation on a captive population is the Nazi concentration camps. The example of the Nazi camps has often been cited in ethical arguments that attempt to sensationalize and disparage opposing views. Furthermore, ethicists especially have used these experiments to throw sand in people's eyes about such issues as abortion and euthanasia, and to create ethical arguments based on the kind of domino theory. In mentioning the Nazi experiments, it is not my purpose to directly compare transsexual surgery to what went on in the camps, but rather to demonstrate that much of what did go on there can be of value in surveying the ethics of transsexualism. The specter of unethical medical experimentation loomed large after the publicity that was given to the Nazi concentration camps during World War II. In fact, one of the first comprehensive codes of medical ethics, specifically dealing with the ethics of experimentation, emerged from the Nuremberg trials in the wake of the famous Doctors' Trial, or, as it is sometimes called, the Trial of the 23. The Nazi medical experiments read like a series of horror stories. The experiments were quite varied. High-altitude tests were done on prisoners to observe the point at which they stopped breathing. Inmates of the camps were subjected to freezing experiments to observe the changes that take place in the person during this kind of slow death, and also to determine the point of no return. Experiments in bone grafting and injections with lethal viruses were commonplace. The much publicized sterilization experiments were carried out on a massive scale at several camps, primarily by radiation and surgical means, for the purpose of seeing how many sterilizations could be performed in the least amount of time and most economically. Thus, anesthesia was not used. However, the point of all this background is not merely to recite a list of atrocities, but to highlight several points that apply to the situation of transsexualism. As Thomas Satz has noted, quote, The activities of the Nazi physicians were unfortunately not the aberrations of a wholly healing profession imposed upon it by the terrors of a totalitarian regime, but on the contrary, were the characteristic, albeit exaggerated, expressions of the medical profession's traditional functions as instrument of social control. End quote. Historically, many physicians aided the Inquisition, actively supported the military efforts of all nations, and today serve as an extra-legal police force to control deviants, especially in the realm of psychiatry, which wields its vast political powers. Today especially, it is no longer the alliance of church and state that should be feared, that is, theocracy, but rather the alliance between medicine and the state, that is, pharmacracy. It is the medicine that presently functions as the new secular religion, with the continuous aid of sustained government support. Not so incidentally, some transsexual research has been funded by federal grants. The Nazi doctors undertook many of their experiments in the name of science, but for the purpose of supposedly gaining racial knowledge, e.g., how did skull measurements differ between Aryans and non-Aryans? The doctors who treat transsexuals undertake many of their experiments in the name of therapy, but for purposes of gaining sexual knowledge, e.g., is it possible to construct a functional vagina in a male body? What we are witnessing in the transsexual context is a science at the service of a patriarchal ideology of sex role conformity, in the same way that breeding for blonde hair and blue eyes became a so-called science at the service of Nordic racial conformity. This leads to the second point to be learned from the Nazi experience, the questionableness of detached scientific fixation and so-called objective knowledge. It must be remembered that such fixation and objectivity led to one of the most profound inhumanities that the world has ever witnessed. It is this kind of fixation, accompanied by a cult of objective truth, which helps to explain why the Nazi doctors did what they did. Quote, a profound inhumanity had long been presaged. That is the alchemy of the modern age, the transmogrification of subject into object, of man into a thing against which the destructive urge may wreak its fury without havoc. End quote. One must remember that many of the Nazi physicians whose experiments were the most brutal refused to recognize in the end that they had done wrong. Dr. Karl Brandt, for example, during his trial at Nuremberg, offered his living body for medical experiments like those he had conducted. Before Brandt met his death at the side of the gallows, he made a final speech which included these words, quote, it is no shame to stand on the scaffold. I served my fatherland as others before me. End quote. It is this kind of scientific fixation, among other things, that impels doctors to pursue transsexual surgery when there are so many more pressing concerns. When our maternal morbidity and infant mortality statistics are outrageously high, when there are still no adequate or foolproof means of birth control, and when breast cancer ranks as one of the greatest killers of women. In other words, transsexual surgery is unnecessary surgery, performed in part because of the objective knowledge that it offers to researchers and technicians on a subject that is not knowable from other sources. It diverts time, attention, energy, and research money away from other medical areas that are more pressing and need attention. It provides a marketplace, so to speak, for the surgical talents of doctors, and it fattens doctors' wallets. Transsexual surgery is not cheap. Prices range from $3,000 to $12,000. As stated previously, it is significant also that both government and private medical insurance plans cover the cost of surgery in some cases. This has always been a financial incentive for doctors in performing surgery. Unnecessary surgery is spiraling, especially during the last quarter of a century. A House of Representatives subcommittee reported in July of 1975, quote, if the scalpels of American surgeons remain as active as they are today, nearly half the women in the country will undergo hysterectomies by the time they're 70. and 1 of every 3 men will have hernia surgery, end quote. The same committee reported that at least 1/3 of these operations was unnecessary and concluded that money was a basic factor in their performance. Quote, "The business of surgery has boomed in the last decade to become a $25 billion pursuit, involving more than 18 million operations a year," end quote. It is not inconceivable that transsexual surgery, and various modifications of it, although it is being done on a minimal level presently, could also skyrocket to high numbers, and that the medical labeling of a condition known as transsexualism will increase the number of people with exceptional medical consumer status. The third point to be learned from the Nazi experiments concerns the information that accrued to medical science because of them. That is not a factor to which most commentators refer. William Scherer, author of The Rise and Fall of the Third Reich, claims that, quote, "In the use of the concentration camp, inmates and prisoners of war as human guinea pigs, very little, if any, benefit to science was achieved," end quote. However, there is other evidence that explicitly states that certain medical experiments that went on in the camps were later taken up and used by science, although the origins of such research were generally hidden from publication. Gutentag remarks that, quote, "Contrary to general belief, some of the experiments that those men performed were scientifically valuable and are quoted in Western literature," end quote. One example of this is the low temperature and freezing experiments. While a medical procedure or experiment should not be determined by its origin, nevertheless its origin is instructive. Applying this to the transsexual context, it is significant that the first physician on record to perform sex conversion surgery was a German by the name of F. Z. Abraham, who reported the first case in 1931. Furthermore, Benjamin relates that the Institute of Sexual Science in Berlin did much work on transvestism, and probably transsexualism before it was named such, under the leadership of Dr. Magnus Hirschfeld. Benjamin states that it had a, quote, "famous and rich museum, clinic, and lecture hall," end quote. In 1933, he says it was destroyed by the Nazis because, quote, "the Institute's confidential files were said to have contained too many data on prominent Nazis, former patients of Hirschfeld, to allow the constant threat of discovery to persist," end quote. Benjamin visited Hirschfeld and his institute many times during the 1920s. We also know that at least one transsexual operation was done in the camps. Joseph Vexberg, in his editing of The Murderers Among Us, the Simon Wiesenthal Memoirs, recounts Wiesenthal's recollection of a victim of the camp's experimental surgery. Quote, "I met another boy whom the scientists of Auschwitz, after several operations, had successfully turned into a woman. He was then 13 years old. After the war, a complicated operation was performed on him in a West German clinic. The doctors restored the man's physical masculinity, but they could not give back his emotional equilibrium," end quote. By this comparison, I do not mean to exploit the very real difference between a conditioned voluntary medical procedure performed on adult transsexuals and the deliberate sadism performed on unwilling bodies and minds in the camps. However, it is important to understand that some transsexual research and technology may well have been initiated and developed in the camps, and that, in the past, as well as now, surgery was not performed for the present professional goal of therapy, but to accumulate medical knowledge. At this point, it is the task of this book to suggest different, and what I regard as more adequate, answers to the questions that transsexualism raises. In Chapter 6, I place transsexualism in a more philosophical context by discussing an ethic of integrity. It is my hope that this discussion will not be regarded as abstract or distracting, but that it will form the basis for viewing the deeper and more mythic aspects of the transsexual phenomenon.